Dear colleagues, welcome to the Endo channel by Gianluca Plotino, the place where I want to give you my vision on endodontics. On this fourth module, we will speak about scouting and glide paths, so I want to give you some background on this topic. My definition of complex cases in endodontics can be divided in primary treatments and retreatments. But when we speak about primary treatments, the very important part that I want to underline to classify a difficult case is the presence or the absence of a scoutable root canal. So I want to give you some definition to clarify what we are speaking about and to define the different phases of these steps. I tried to give this definition in a couple of review articles with some very good friend of mine from all over the world that we have submitted for publication in international literature. Here, I hope you will find this definition very clearly in a scientific article. When we speak about this phase of endodontic treatment, the initial steps after the access cavity and the orifice location, we are speaking about the scouting and negotiation, the glide path, and the preflaring. So I want to give you the definition of these steps. Scouting and negotiation can be defined as the passive exploration phase of the canal using small files which are proposed to appreciate the morphology and coronal patency of the canal and its resistance to file penetration. The glide path phase can be defined as a smooth radicular channel from the canal orifice to the physiologic terminus of the root canal. And the glide path is achieved when the file forming it can enter from the orifice and follow the smooth canal walls uninterrupted to its terminus in an effortless way, usually using a stainless steel K-file size 10. This is nice to underline these two terms that has been used for defining the glide path, the smooth radicular tunnel and obtained in an effortless way, because these two terms comes from another type of glide path. I found this definition of glide path that origin from the aeronautical field, in which the glide path is the approach path of an aircraft when landing, usually defined by a radar beam. And to define this aeronautical glide path, they use the same two terms because you must move silently and in a smooth and an effortless way. So this is curious how the glide path has been defined in so two different topics. When we speak about preflaring instead, it's meant as a pre-enlargement of the root canal up to its terminus using end files to a tip size at least equal to that of the tip of the first rotary instruments that will be used. This part, this preflaring has been created to reduce the possibility of an instrument of a rotary file to be blocked inside the root canal, to reduce the risk for fracture by torsion. And there can be also a coronal preflaring, so the preventive elimination of coronal enlargement, of coronal interferences to create a pre-enlargement of the coronal portion of the root canal to make the advancement of the rotary files easier inside the root canal. In these reviews, we have also defined another term, the natural path. The natural path can be defined as an anatomic path that is always present in nature because it is created by the neurovascular bundle that penetrates from the apex and reaches the coronal portion of the tooth. So we always have a natural path. And in the dynamic endodontic concept, we have to say that the scouting and negotiation phase can be done at the beginning, but also repeated during the glide path preparation or during the preflaring preparation or during the instrumentation as a recapitulation phase. And also the preflaring can perform it, for example, before obtaining the glide path as a coronal preflaring when we have difficulties to advance, and so we can create the conditions to obtain an apical patency that is more difficult. So the first rule we can give you is always start with a manual scouting performed using small and not pre-bent stainless steel files using starting from size 0.08 K file or 0.06. This may help you to understand if there is a scoutable or an unscoutable anatomy. That is something that can classify our endodontic cases. So if we have an anatomical path that initially can be scouted, we can define it as a standard case. If we start to do as initial scouting without any effort to work inside the root canal, but just to study the anatomy as we have defined it, and this canal is initially unscoutable, we can define this case as a complex case. So we will see in this module of my endo channel the cases that can be defined as standard, and that is they are the majority of the cases, and most of all, we will check the strategies how to treat the few unscoutable canals that are the most complex canals for our scouting, glide path, and preflaring strategies. We will see this on the next appointment on complex scouting and glide path on Endodontic channel. Dear colleagues, welcome to the Endo channel by Gianluca Plotino. In this module, I will give you my vision on complex scouting and glide path. And as I have anticipated when I have discussed the topic of the ideal instrument for root canal preparation, there are many ways to achieve a result, also in the scouting of complex canals. But as I always like to mention, if all roads lead to Rome, I hope you will follow my vision on this topic on different difficult scouting of root canals. As I have always underlined, speaking about dynamic endodontic concept concerning the scouting and negotiation, glide path, and preflaring phases, these phases can be also interchangeable. For example, the scouting and negotiation can be performed at the beginning to study the root canal anatomy, or can be performed also during the glide path preparation, the preflaring preparation, or during the instrumentation for obtaining the recapitulation. But also the preflaring phase, for example, can be performed after the glide path or before the glide path as a coronal preflaring if we need to obtain an apical patency that is difficult to be obtained. When we speak about scouting and glide path, my rule is always to start with a manual scouting that can be performed with small and not prevent stainless steel file. Usually I start using the size 8K file or the size 6K file in most difficult and strict root canals to study the root canal anatomy using the scouting. As we have defined, this phase aims to enter inside the root canal without working in the root canal, just to explore the anatomy, to understand the orientation of the canal, to understand if the canal is penetrable up to the apical foramen. This is the scouting or negotiation phase. So during the scouting, root canals may be successfully negotiated up to the apex because it's easy to understand that if we go with the size 8 stainless steel file inside the root canal that is patent, we can easily penetrate this root canal without any effort or without working, and we can reach the working length under the control of the apex locator. In my past years, I have reviewed the cases that I have performed, and I have seen that the root canals are patent and the anatomical path is present and scoutable in around 85% of the root canals. Those are all root canals that I have treated, so probably in the anterior teeth, single-rooted teeth, this percentage can be increased to 90 to 95%, while in molars, where the scouting may be more difficult, it can be reduced to 75-80%. Those are the percentages that I can give you. And if a root canal, if successfully negotiated during the scouting, we can affirm that a natural scoutable glide path is already present. As we have defined, the natural path is the presence of a space from the apical foramen to the coronal portion of the tooth given by the presence of the neurovascular bundle. So this space is always present in nature. The problem is if we are able to successfully scout and negotiate this space. So if this natural space, natural path is scoutable, it means that since the beginning, it means that is already present a natural glide path inside these root canals. That is this more or less 85% of the root canals that we can encounter. So in that case, the anatomical path is initially scoutable without any efforts during the scouting procedure with a size 8 or 6 stainless steel file. We classify this case as a standard case because this is a case in which the natural path helps us to reach the working length without any efforts because of the quality of the instruments that today we have on the market. I define this case as standard even if they are very curved, very long double curvatures, because the instruments that we use today and are on the market today permits us to have a strategy to prepare even the most curved and difficult root canals in these cases in which there is a scoutable space very easily, very efficiently, very fast, and among all, safely. If a root canal is successfully negotiated during scouting in these standard cases with a stainless steel 6 and 8 files, then we have a scouted root canal, negotiated root canal, in which we have to prepare the glide path. And we can do it with manual files or preparing the mechanical glide path and pre-flaring. This is up to the clinician what they prefer to do. For example, in this case, in this first lower molar, passing through the crown, removing the calcification of the pulp chamber, as we have seen in the orifice location phase, and as soon as we have identified the orifice location, in this case, I have started with the size 8 stainless steel file to establish the scouting and to study the root canal anatomy. I studied the root canal anatomy and I reached the working length with this file, working length controlled with the apex locator. So after scouting, I can create the manual glide path up to a size 10 stainless steel file very easily, because after the 8 stainless steel file, it's very easy to reach the working length with the 10 stainless steel file. And as we have given the definition of the glide path in the background of this lesson, the glide path is achieved when a stainless steel K file, not pre-bent, reach the working length and moves up and down from the orifice to the foramen in a predictable, repeatable, uninterrupted way up to the terminus of the root canal. This is the glide path. So in this case, the preparation of the glide path has been done with a manual file, stainless steel size 10. We can limit the manual glide path to this stainless steel 10, and then we can start working with mechanical files to prepare this root canal and then fill the root canal if we use the mechanical files that are suggested to be used only after just a scouting with a size 10 stainless steel file and not more with the bigger sizes. And this is the 5-year controls of this case with the complete healing of this lesion. So when we used in the past the rotary files, I have to underline the rotary files always need a manual glide path, always need the use of stainless steel file before. This is a case that I have published in 2008 of a mandibular third molar with 3 mesial root canals, a case report published on Journal of Endodontics. And in this case, at that time, using rotary files, I found 3 separate roots in the mesial portion of the tooth, and 3 separate root canals, and I have established the glide path with manual stainless steel files up to the terminus, and then I started with the rotary technique, starting with an instrument with C-tip size 10 taper 4 that needed only a scouting and glide path prepared with the size 10 stainless steel file before to start with the mechanical instrumentation. So I always did like this with rotary files because rotary files needs glide path to prevent fracture. And those are the 1-year and 5-year controls of these cases. So the rule in glide path and preparation for rotaries is always a manual game performed with small and non-pre-bent stainless steel K files. So the glide path is usually prepared up to size 10 instrument as for definition. Then for some rotary files, we cannot stop to 10, and we need also a pre-flaring with 12 or 15 stainless steel file to create a root canal, to create a space that is the same tip size of the first nickel titanium rotary files that we should use. So it depends by the instrument that we will use, but all rotary files are recommended to be used after a manual glide path to at least a stainless steel 10 files. Most of the techniques that we have used, the rotary techniques that we have used, suggest this. Some techniques suggest also to expand the glide path, enlarging the pre-flaring up to size 15, for example. And this depends by the quality of the file, by the size of the rotary files that we have to use, the flexibility of the file. If it needs an expanded glide path, that means we have to create a pre-flaring for these rotary files. But normally, usually today, all the rotary techniques just recommend a scouting with a 10 stainless steel file before using the first rotary file inside the root canals. This is true also for the so-called glide path files, glide path mechanical files. So today on the market, they are marketed as glide path files. We have a lot on the market, but all these glide path files, these defined glide path files, they suggest the use of a 10K file before the use of the glide path file. They are marketed as mechanical glide path file. But honestly, I have to say, after this explanation of the endodontic terms that I gave you, that if we have already established, already used a stainless steel 10 file up to the end before to use a mechanical glide path files, it means that we have already established a manual glide path as for definition. Because when we reach the working length with a stainless steel 10 file that goes uninterrupted to the terminus of the canal in a predictable, repeatable way, in a smooth root canal wall, we already have a glide path for definition. So we need this to start using this mechanical glide path file. So we are using this mechanical glide path file in a canal in which we have already obtained the manual glide path. So I don't like to use the terms glide path instruments, but I like to call them as mechanical pre-flaring instruments, because these instruments, honestly, they are only doing a pre-flaring to perform the preparation with the subsequent sequence of rotary files. They are not mechanical glide path files. So we are performing with this file a mechanical pre-flaring, not a mechanical glide path. What I can say here is that the presence of an advantage, the presence of a scoutable natural path has the advantage to give the clinician the possibility to start with the mechanical files immediately after a manual scouting and glide path preparation up to size 10, reducing the possibility and the possible errors induced by the use of more rigid stainless steel files that are used for pre-flaring. So these mechanical pre-flaring files aims to start earlier with the mechanical instrumentation, to avoid the use of stainless steel files of bigger sizes like 15 and 20 that are very rigid and with which we can create damages inside the root canal. We can create iatrogenic damages, iatrogenic problems like ledges or zips or transportation. So the mechanical pre-flaring has a very important advantage respect to manual pre-flarings. The disadvantage of manual pre-flaring, of preparation of pre-flaring with hand files, is that a longer preparation time is needed to do it manually. We can introduce the risk for canal aberration like ledge, zips, or apical transportation. By using manual files in a correct way, it's needed a level of expertise that is higher rather than to use a mechanical file. So there is a longer learning curve, because we can introduce more errors using rigid stainless steel file. The operator fatigue is higher because by using manual files we do a lot of efforts more. With manual files, we can increase the apical extrusion of debris because of the movement of manual files and the type of cutting of manual files, and we consequently can increase the post-operative pain. So after these explanations, what do we really need in this phase of the treatment? we really need a real glide path file, not the glide path file that are already marketed today that can be used only after that we have established a manual glide path with a 10 stainless steel file, as I have explained. We need a real glide path file that can be used only after a small scouting phase initially, in which we can arrive to the working length without any work, because there is a natural path scoutable. And so the use of a reciprocating motion permits to prepare root canals without any prior glide path, as I have clearly explained in the previous module of this endodontic channel, when I have described the ideal characteristics of an instrument for root canal preparation. Because when a reciprocating file binds inside the canal, it will never rotate past its specific angle for fracture. So therefore, the creation of a glide path to minimize bonding that has been a rule for rotary files is no more a rule, and it is no more required for the reciprocating instruments, because of the advantage of the reciprocation itself that prevents the tip of the file to bind inside the root canal, so to prevents the taper lock of the tip of the file, and so prevents the fracture by torsion if the tip of the file is blocked inside the root canal, as it may happen for the rotary files. So glide path pre-flaring procedures, they have been introduced for rotary files to overcome a limitation of the rotary file, that was the possibility that the tip of the file could break because engaged inside the dentin and broken for torsion. This cannot happen for reciprocating files. So I'm speaking here about the first reciprocating glide path file, because this is the first file that we can use to create a real mechanical glide path. And we can use it as a universal glide path because the indications for the use of this file are that we can only scout the root canal up to a size 8 stainless steel file. We don't need to create a glide path, a smooth radicular tunnel with a size 10 stainless steel file. With this instrument, the indication and the instruction for use says us that we can use it just after the size 8 reach the working length, has a glide path and pre-flaring file altogether, because this is an instrument, a tapered file that not only prepare the glide path after the size 8, but also prepare the pre-flaring and pre-enlarge the root canal before the use of any system for root canal preparation that you prefer to use. And I have underlined in the lessons on the characteristic of the instruments, which is my system of choice for root canal preparation. So in this clinical video, I show you what I normally do in clinical cases. I start with preliminary scouting immediately after the preliminary opening of the access cavity. In the molars, I start with the 8 or with the 6 stainless steel file with this watch winding movement without working on the file, without trying to bypass any difficulties. If this file follow the natural path, even in presence of a small apical curvature like this, as we have seen on the file, it means that there is a natural scoutable path to our stainless steel file. So after the 6, I use the size 8 stainless steel K file under the control of the apex locator with this small watch winding movement without working on the file to try to reach the working length. Just exploring the apical path. And look, there was an apical curvature, abrupt apical curvature, but the natural path was explored because the trajectory was compatible with this stainless steel file. So immediately after the size 8, I start with the mechanical reciprocating file. Given and thanks to the properties of these files and the properties of the reciprocation, we can use this instrument inside the root canals immediately after size 8. We have seen why reciprocation is a very important advantage to perform this initial preliminary scouting mechanically. We will see why specifically this AirPilot file is a very great instrument and the ideal instrument to performing the scouting even in the most difficult cases in the next part of this lesson today. So as you can see, the instrument is used with 3 to 5 pecking motions, advancing more or less 1 millimeter each motion, and then each peck, and then irrigation. We can perform a brushing action to selectively remove the interferences with the use of this file, because this file has very good cutting efficiency, very good lateral cutting ability. So during brushing, when we go outside from the root canal, we can remove the coronal interferences to prepare the preflaring for the root canal preparation with the next file. And then after the preparing of the glide path and the preflaring, we start with the activation of the irrigants, with the stepwise intraoperative activation that we will see in the lesson on the irrigants and irrigation protocol. Then, after the glide path created with this system, the tough decision ahead is to use our system of choice to complete the root canal preparation, because in this standard case, honestly, the work is almost done as soon as we have finished this scouting, glide path, and preflaring preparation with mechanical file. And the use of an instrument today we have a lot of very performant instruments on the market, mechanical files, both rotary and reciprocating file with very good mechanical properties that can easily prepare this kind of standard root canal, honestly. But my instrument of choice, I have already anticipated, I have already described it in very well details in the lesson on the ideal instrument for root canal preparation, is a reciprocating file, because of all the advantages of reciprocation, is a thermally treated night-eye alloy file, because of all the advantages that we have described on this topic. Is an instrument with a high cutting efficiency and a high flexibility and fatigue resistance that both properties permits the instruments to advance easily inside the root canal, even in the more constricted root canals, and to advance and to penetrate even the most difficult curvatures or double curvatures in a safe way. I have also described in the lessons on the ideal instrument for root canal preparation that an ideal file should permit a single file technique and should permit to negotiate the root canal using directly a mechanical instrument without any glide path, and also is an easy and efficient retreatment for filling material with this ideal file. So those are other characteristics for the ideal instrument for root canal preparation. The ideal instrument for root canal preparation for me, I have already described it in the other lessons. Join new movements like reciprocation with new approaches like the mechanical glide path with new night-eye alloys with metal treatments. And the instrument that I'm presently using for all these cases is the Reciproc Blue. In my classification of standard cases, in more than 85% of the case, you can use directly the Reciproc Blue file only after the scouting or without any scouting, as we have seen in the lesson on the root canal preparation, because this file aims to prepare the coronal and middle third without any glide path. So we can start directly with this file, and we need a scouting and glide path only in the apical third. So with this instrument, we can use different strategies. If we like manual scouting and manual glide path, we can use manual file to the working length before this file. If we like mechanical scouting, we can perform just a small scouting with the size 8 and then perform a mechanical scouting with our pilot and then use this file. Or if we trust in this technique, we can start directly following the manufacturer instructions by using this instrument for the coronal and middle third scouting, glide path, and root canal preparation directly with the Reciproc Blue file, and then pass through an apical scouting as the manufacturer instruction with the stainless steel 10 file, and then use the instrument also in the apical third. And this is one explicative and simple case just to see the use of this instrument in these standard cases where we have a standard scoutable anatomical path, even if these root canals are very curved, but if they were initially scoutable with hand files, we can prepare with these instruments very easily, very fast and efficiently. And this is the final radiograph after the preparation with the two very curved mesial root canals, the two confluent, very curved distal root canals. The other situations that we are going to describe more in depth during these lessons are when there is not a scoutable anatomical path. So in my retrospective analysis, the percentage of cases in which a scoutable anatomical path is not initially present during the scouting phase, the studying of the anatomy of the root canal is around 15%. This is the percentage of all root canals that I have treated in the past years. As I have anticipated for the scoutable root canals, if we divide this percentage for the type of teeth, probably if we go to analyze the anterior teeth, the single-rooted teeth, this percentage is lower and it goes from 5 to 10%. If we are going to analyze the molar, this percentage is higher and it probably goes to 20-25% of canals that has not an initial scoutable glide path in which we have to work hard to obtain it. Because in this case, clinicians have to form this glide path and to form the anatomical path with some different strategies. So in my classification of complex cases in endodontics, the initially unscoutable anatomical path means that we are in presence of the real complex cases in which the clinician has to do something different to perform these difficult treatments, because the instruments that we have today on the market permits us to prepare standard canals with scoutable anatomical path in a easy, fast, and efficient way, even if they are very curved or very difficult anatomy, as we have seen before. But when we have not scoutable anatomical path, even if the canal is not very curved, this is the real complexity that we have to face with. And when we define the unscoutable anatomical path, we can define two different clinical situations that we have to deal with. The first situation is given by difficulties due to coronal trajectory or calcification. So difficulty to scouting the anatomical path for coronal trajectory or coronal calcification. The other situations is given by the difficulties to perform the scouting due to apical curvatures or really tight root canals. So let's go to see which are the strategies for the scouting management of these more difficult situations. The first one is the scoutable anatomical path given by difficulty due to coronal trajectory or calcifications. The first very easy example that we can do for this situation is, again, the MB2 root canals. We have spoken about the MB2 root canals during the orifice location lesson, because these MB2 root canals has this amount of dentin that cover the orifice of this root canal. And so the first step to treat these root canals is during the orifice location phase to remove this part of dentin, to find an orifice, to find an invitation that then can be prepared to move the root canal at the end of the preparation, as we can see here in the image after the preparation of both MB root canals. And this is the radiograph of the scouting, the apical abrupt curvature of this case with the confluent root canal, and the final radiograph after filling. Now, in this lesson, we are going to speak about the further step after orifice location, because in this case, as soon as we have found the orifice of these root canals, the most explicative of which is the MB2 root canal, we need to scout this orifice. So as soon as we found the orifice today, I want an instruments that permits me to immediately scout this orifice that I found without the need to go deeper inside the root with more aggressive techniques like burrs or especially ultrasonic tips. So as soon as I found an invitation, I want to treat this orifice as soon as possible by mechanical files. So in this case, the problem of these root canals is that this amount of dentin that is covering the MB2 moves the orifice of the root canal in towards the center of the pulp chamber, giving the direction, the direction of the entrance of this root canal, a very inclinated distal direction for this MB2 root canal. So in the first 2, 3, 4 millimeters of these MB2 root canals or similar root canals, we have the root canal that has this particular trajectory, this particular inclination from distal towards mesial, because of the presence of this part of dentin that is covering the orifice and moving the canals toward the center of the tooth. After this initial trajectory, we have a point in which the curvature is shifting towards the opposite direction. So in these roots, the curvature then is moving distally, and usually or buccally or apically or palatally. So we usually have a double curvature in these roots, but the main anatomical feature that I want to underline you is this change of inclination of in direction of the canal from distal to mesial in the coronal portion, and then from mesial to distal down the coronal curvature. Because this is the point in which we have difficulties for the coronal scouting. After we have found the orifice, this is the trajectory in a three-dimensional reconstruction of an MB1 and an MB2 root canal, and you can see this type of trajectory. We are in the middle of dentin in the coronal portion of the access cavity, and this is the amount of dentin that cover the trajectory of the root canal. This is the furcation, and this is the trajectory, a trajectory that goes mesially in the initial part, and then there is a point here in which, and go also buccally in this case, and there is a point there here before the conjunction with the main root canal, in which then the root canal goes towards distally after the curvature. This is the anatomical complication that we have to deal with in scouting these canals. And we are speaking the moment in which we have an invitation, not the moment in which we are looking for the orifice. So after the orifice location, after we have identified the orifice and we see a space that is start to be penetrable to our hand files, and we start the scouting with our hand file, this is the MB1, this is the MB2 root canal with a big connection, big isthmuses inside the two root canals, but you can see the MB1 root canal is moved more mesially. The MB2 root canals is moved more towards the center of the pulp chamber floor because of the presence of the dentin here that moves the root canal there. Then the root canal, when we will finish the root canal preparation, as we will see here in purple, will be moved on the same plane of the MB1 root canal after the root canal preparation. And here you can have a look on the amount of dentin that we have to remove for at the end of the preparation of this root canal to permit a safe, effective, and predictable preparation of this MB2 root canal up to the terminus. So we can remove this amount of dentin, this triangle of dentin, with different strategies. We can remove this amount of dentin with ultrasonic tips, for example, but we need to go deeper inside the root, up to this level, 2, 3, 4 millimeters deep inside the root with aggressive ultrasonic tips, and I don't like to do it very much. So I use ultrasonic tips only up to this level, just to find the orifice and the invitation of the root canal. Of course, if the orifice is moved apically, we have seen in the orifice location lesson, we have to go deeper with the ultrasonic tips. But as soon as I find the orifice invitation here, I stop to use my ultrasonic tips to try to be as much conservative as possible towards this part of the root that is very important for the long-term resistance of the teeth, as we have seen in the access cavity lesson. So the strategy is to go deeper with the ultrasonics. I don't like it very much because it's more aggressive. So the second strategy is to try to do it with a scouting manual preparation since the beginning. So without removing any coronal interference, just using the manual file, we can see in this superimposition before and after the preparation how the root canal has been moved before and after the preparation. So if we start here with the manual file for the scouting without any pre-enlargement of this orifice, it will be very difficult for our manual file because it's constricted in a very difficult trajectory from distal to mesial, and then it arrives to this point that is the point of the center of the coronal curvature, in which the tip of the file will be constricted here by this trajectory without any preoperative enlargement, and usually stops here. These are the several cases that we find in the clinical practice in which we found a difficult to scout this portion of the root canal by manual file, because the manual file is able to scout 2-3 millimeters coronally of this MB2 root canal, and then we stop and we cannot advance. This is the reason, because of the presence of this anatomy, of this trajectory, and this point of coronal curvature in which the tip of the stainless steel file is rigid, touch and stops and risk to create a iatrogenic error. So with manual scouting, it's difficult to perform this scouting, and this is the experience of all the clinicians that with manual files, we stop usually 2-3 millimeters, and then we cannot scout the MB2 root canal more than this distance. This is for this reason. And if we insist with manual files in scouting this anatomy, it is possible with the manual skies to create a micro ledge in this area, in this point, in which the tip of the file push against the center of the coronal curvature, because it's pushed there by the dentin interference here, the trajectory, the very sharp, hard trajectory that it has to go, it stops here, and if we work with an end file there, we can create a micro ledge there that then will create a very difficult impediment for the proceeding of the procedures in these cases. So do not insist in these cases with the manual stainless steel file if it does not proceed following a scoutable natural path. Do not insist, because the manual files are rigid, especially starting for the 10, and can create this iatrogenic anatomical error problem that can prevent our scouting in the next phases. So in these cases, what I like to do is a different strategies, and I like to use an instrument mechanical file made for the scouting for the root canals, for the coronal scouting of the root canal. So the ideal instrument for scouting coronally unscoutable root canals has more or less the same properties of the ideal instrument that we have seen for the root canal preparation. These properties are that this instrument must not need a glide path, because in this case we don't have a glide path, because we tried, for example, with a manual scouting, and it was not possible to scout this root canal. So we stopped before working with these manual stainless steel rigid files, before creating a problem, a ledge or an error. So in this case, we don't have a glide path. So we cannot use an instrument that must be used only after the creation of a glide path. So we need an instrument that doesn't need the glide path. And this is an instrument that is used in reciprocation, as we have seen in the lesson on the ideal instrument for root canal preparation. This is an instrument that can be used as a single file with a tip size and taper compatible with this anatomy. This is an instrument with an high cutting efficiency, and then to cut this dentin, this coronal dentin, and penetrate this really strict canal, really hard dentin, with a high flexibility and fatigue resistance to follow these coronal curvatures and then the subsequent more apical curvature that is always present in another plane without risking for separation or for fracture. So these instruments doesn't need the glide path. We clearly know from the previous lessons that the use of a reciprocating motion permits to prepare root canals with only one file without any prior glide path. Gassan-Yared has introduced this technique in 2008 and then has produced his own files on the market since 2011, in which the clinical technique described for this file was a clinical technique without any prior hand filing, because when a reciprocating file binds in the canal, it will never rotate past its specific angle for fracture. So the creation of a glide path to minimize binding in these cases is not required. And this concept of mechanical glide path has been demonstrated very successful with this reciprocating file. Starting with the reciproc 25 file, the studies of my very great friends Gustavo, Eric from Brazil have demonstrated that this preparation of the mechanical glide path in the coronal and middle third is able to reach the working length in more than 96% of the cases in straight root canals and more than 90% of the cases in curved root canals. In this other article, again by this very skilled clinician with also Evaldo Rodriguez and Manuel Silva, they have even higher percentages of success, 95, 98, 97% successful root canal preparation safely performed without any glide path with a reciprocating file. This is with reciproc M-wire, but the same results they have obtained with the reciproc blue. The evolution of the reciproc M-wire, in which, in this study published in the last months, they have obtained more than 98% successful scouting and negotiation with the reciproc blue 25 without any glide path in slight to moderate curved root canals. So these numbers are very successful. In this other study, the frequency of reaching the full working length was compared with the original technique given by any hand file before, or with compared with a glide path obtained by manual scouting or by mechanical scouting with their pilot, and the frequency of reaching these working lengths was not different among reciproc blue, or both these files used after a manual glide path with C-pilot files or after a mechanical glide path with AirPilot files. So more or less we have the same results and the same efficacy in scouting these canals without any prior hand file before. So these other articles made by great clinicians like Mario Zuolo, Maria Cristina Carvalho and Gustavo De Deus has been performed specifically on the MB2 root canal, so on the scouting of the most difficult root canal in the mouth. And this is really clear to demonstrate the efficacy of this technique for the scouting of this root canal. More than 85% of the MB2 root canals has been scouted like this, while only 57% of MB2 root canals were successfully scouted with end files. So the difference is very big, and it's crazily surprising if you don't know the instrument and if you don't know the technique, because we are speaking about a manual small file 6, 8, 10 that is not able to scout a root canal, and a big file like a 25 taperate in the tip that is instead able to scout this very small root canal. So the difference is crazy, but this is what really happens clinically. And this is a clear explicative video of an unscoutable MB2 root canal after the orifice location. As soon as we find the orifice and we find the invitation, I use the tip of this file as a probe, as a mechanical probe, as a probe in mechanical movement. This is like a probe. I go in the invitation of the orifice, and then I start the movement. The tip 25 taperate for 3 millimeters is flexible enough, but has the metal mass enough to penetrate these coronal interferences, this coronal trajectory. The flexibility of the file permits the file to follow this coronal curvature without modification of this curvature, other than the modification that we need to penetrate this root canal, so the relocation of the orifice more measured. After the middle and coronal third preparation of this root canal, the technique aims to scouting the apical third. But in these cases in which we have a coronal impediment to the mechanical scouting, the apical scouting, it's easy to be performed with a stainless steel file, and we can finish the mechanical preparation with the same instrument up to the terminus of the root canal. So in this video, you have clearly seen how this technique can help us in scouting the coronally unscoutable root canal. I want to repeat the properties that this file has to help us to perform this scouting in these particular situations. The big tip is big enough and resistant enough to, and has enough power to penetrate this hard dentin that occlude the coronal portion of the root canal. The cutting efficiency of this file gives the file the power to push a bit on the tip to penetrate this dentin and to cut this dentin, and if the instrument cuts the dentin, then it follows the path of least resistance given by the root canal, and so cutting dentin follow the path of least resistance, follow the original trajectory of the root canal by performing the root canal instrumentation. And it has the flexibility to perform it even in a curved canal, even in a very curved coronal in a very strong coronal curvature given by the anatomy of this root canal. So this is very important characteristic to perform this, and there is no risk to create ledge or to make a perforation because the flexibility of the file, the cutting ability of the file permits the file to follow the natural path already existing, to follow the path of least resistance that is given by the natural path of the root canal, even if we push a bit on the file to penetrate this hard dentin. And this is the final radiograph of this case with the two separate mesiobuccal root canals. The ideal instrument for scouting of coronally unscoutable root canal is also a reciprocating file, a file with a reciprocating movement. I will not repeat all the advantages that the reciprocating movement has: the safety, the higher fatigue resistance than rotation, the cutting efficiency as full rotation, the equal or better quality of the preparation, because I have clearly described in details all these advantages on the lesson on the ideal instrument for root canal preparation. So those are all the advantages of the reciprocation that we can keep for preparing this kind of very complex root canals. Another characteristic that the root canal should have for coronally unscoutable canals, so just we concentrate on the problem on the coronal scouting, on the problem on the coronal third. I want a single file, so a file that has a tip size and taper big enough to have the power to scout these difficulties in the coronal thirds. And we have seen in the video, in the clinical video that I show you, that a single file has a tip size and a taper in the tip that permits to this file to be used in such kind of the root of anatomy. Then the variable taper of this file means that in the middle and coronal third of the instrument, this instrument is smaller than a 25.6 constant taper. So being also conservative in the coronal third, reducing the amount of dentin removed respect to a 25.06 taper. But here we are concentrating on the tip of the file, and the tip of the file has these characteristics that can be used as a single file in reciprocation, because the working area of this file in these root canals is the tip of the file. The tip is 25, taper 8 for 3 millimeters, so the tip has the power to cut a big amount of dentin in a very small coronal third, has the cutting efficiency to do it, has the flexibility to do it, and the safety to do it thanks to the reciprocation. So these properties, for doing this, we need a tip that is resistant and that can be pushed a bit inside this anatomy and can follow the hollow path of least resistance given by the root canal because of its characteristics. So the tip is very important. A small tip in this case, we will see sometimes, or most of these cases, it's too soft, it's too delicate, it's too small, too tiny to perform this. We need a more aggressive tip to remove and eliminate this coronal dentin that create this anatomical path, this trajectory that is unscoutable to manual scouting file. And this instrument gives you the tactile feedback. I have used these terms. It's like a probe that is activated mechanically. So it's like an extension of your hand, it's like an extension of your fingers. When you use a probe, you have the tactile feedback of what you are touching. You find the orifice, you find the canal. So with this instrument, you are using it like a probe, you find the orifice, then you activate, and you have a mechanical probe, very efficient and flexible, that permits to scout these root canals. Because this single file in reciprocation cutting with the tip can work without any glide path in a root canal that is smaller than the tip of the file, enlarging it following the path of least resistance, using a packing motion, so up and down packing, just as we will see in all the videos that I will show you, just pushing a bit on the tip, small packs, short packs, fast packs, but aggressive packs that permits the instrument to advance and to engage the tip to cut dentin and to penetrate the root canals. As it happened in this other root canal, the second upper molar with this big periapical lesion, after removal of the bridge, it has been treated, endodontically treated, and also the MB2 root canal, even if confluent, was treated with this technique with the respect of the root canal anatomy and with the respect of the root canal trajectory, respecting the thickness of dentin there in the mesial aspect that permits us to build up a restoration that can be long-lasting. The high cutting efficiency and the high flexibility and fatigue resistance I have insisted as really important properties of the design of the instrument in general, but also for performing the coronal scouting of these root canals. The file design is important for this. Obviously, the two blades as shape, cross-section, and file design with these sharp blades is the design that permits us to have the maximum cutting ability and the maximum flexibility for a big file like this. A big file like this that I call the fat boy, because this may solve the problems in the coronal and medial third. It's like an hammer. In this case, we need an hammer to penetrate these unscoutable root canals. We need an hammer to penetrate it, so we need an instrument with these characteristics that can follow the path of least resistance, as in these clinical cases. This video, after the orifice location, we tried with the manual scouting, and you can see the size 8 stainless steel K file is not even able to penetrate more than 1 or 2 millimeter this orifice that we are located. So the first strategy here can be to use ultrasonics to penetrate more deeper inside this root, but I don't like it because it's more aggressive and less conservative. Manual file doesn't work at all, so the other strategies we can use a tip size 25 taper 8 that is powerful instrument. In this case was a reciproc M wire that was available at the time on the market, and look how easy it can penetrate this kind of anatomy. Because of this cutting efficiency, it cuts dentin penetrating inside the root canal. Because of its flexibility, it follows the path of least resistance of this MB2 root canal, and then after the removal of this coronal interference, after penetrating 4 or 5 millimeters of this root canal, you will see it's much easier to penetrate apically because we have relocated the orifice, we have moved the orifice, we have removed this interference, we have reduced this coronal curvature. Most of the cases, this MB2 root canal is confluent on the MB1, and so the apical third, in most of these cases, then can be easily scouted after this coronal root canal third preparation. And this is then the final radiograph, very curved root canals, MB1, MB2, confluent after the curvature, and the rest of the treatment. This is a no glide path technique, as established by the manufacturer. So with this technique, it's possible to negotiate and shape the root canal to the 2/3 working length, using directly a reciproc blue file. Obviously, this is given for the middle and coronal thirds of the root canal. Then the technique aims for an apical scouting with a stainless steel file controlled by an apex locator, what we call the 10 rule. After the medium and coronal third preparation, with the size 10 stainless steel C-pilot file not pre-bent, we have to reach the working length with the control of the apex locator. And in most of the cases, after the coronal and middle third preparation, we are able to reach the apical third. We have only some exceptions in which we have apical difficulties to the scouting. So in these canals in which we have a coronal difficult to the scouting, most of the cases then we have solved it. In some small percentage of cases, the apical difficult to scouting is summing to the coronal difficult of scouting. But in most of the cases, a 10 stainless steel file reach the working length in this case, so then we can complete the preparation with the same instrument. But there are some cases in which the 10 stainless steel file cannot reach the working length even after the coronal preparation, coronal preflaring of the coronal and middle third. And in these cases, the studies says us, the same studies that before I have cited to demonstrate how effective it is to create the glide path, in this study, the authors have also tried to reach the working length in that cases in which the 10 stainless steel file didn't reach the working length. So in these cases, they were the cases of coronal preflaring, coronal preparation of middle and coronal third, and the apical scouting was not possible with the 10 file, and we have to decide what to do. In this study, they have decided to try to reach the working length with the same reciproc blue 25. And in 90% of this small percentage of root canal, they were able to reach the working length with the reciproc 25 file, the reciproc blue, when a stainless steel 10 didn't reach the working length. Just by adapting the technique, pushing a bit on the file, it followed the path of least resistance and created the glide path, even apically. I have similar numbers in my clinical practice with on the reciprocating scouting when the scouting was impossible with manual stainless steel files. So the same situation. Coronal preparation, middle third preparation, then the apical scouting was not possible. In these numbers made with my partner Nick Grande and Pier Francesco Porciani, 70 unscoutable root canals in primary treatments, 94% of which were successfully made patent by the reciproc file in this study. So 66 to 70, so the same percentage as the reciproc blue study by Gustavo de Deus. We have performed this study also in retreatments, 120 unscoutable apically unscoutable root canals in retreatments. In this case, 77.5% of cases successfully made patent apically by the reciproc file, so 93 canals on 120. So in these cases, we have a further possibility with these files. And these are clinical examples on how to perform this technique. This was an upper molar, mesial root canal, manual scouting. We missed just 1 or 2 millimeters of the apical third, but more, and then we pushed with the reciproc file to reach the working length. But more interesting, the distal root canal, more evident, we miss all this part of the root canal, couple of millimeters of the root canal. With the hand file, we were not able to reach there. So I do not insist in these cases with the hand file, and we can use the reciproc blue 25 to follow this double curvature to scout this apical third where a manual file was not able to do it, just pushing and go away, as I will show you later. And this is the final radiograph of this treatment performed by this technique. So in these cases, we know that this technique can be helpful not only for the coronal scouting, but also for the apical scouting. And it can be helpful also in the retreatment for the apical scouting. When we have a short root canal treatment, usually we can find a calcified portion of the apical third of the root canal. In this case, it was not possible to penetrate by hand file more than this after removal of the filling material because of calcification of the apical third of these canals. It usually happens in root canals without any periapical lesion because they were root canal treatment short, in which the pulp was not infected, was vital, and reacted to the endodontic treatment that has been performed coronally and closed the root canal. So if we have this situation, usually we don't have infection and we have reaction of dentin that obliterate the apical third of the root canal. So in this case, we can work with this technique by working with the tip of this reciprocating file with a 1 second pushing action and go away. And proceeding slowly, very slow, perhaps we cut 0.2, 0.3 millimeters, maximum 0.5 millimeters each time that we do only one stroke apically and go back. And we very slowly reach the working length, cutting this type of dentin, very small amount of dentin, penetrating very slowly. Probably we need 2 or 3 new files to do this technique because we do a very big effort, very big power action on the tip of the file to cut this really constricted root dentin, the really hard dentin, reactionary dentin, but the instrument, as you can see by this radiograph, follow the path of least resistance given by the root canal and the reactionary dentin. So by doing this technique, we are able then to perform the scouting, the glide path, and the preparation all together, and then we can fill the root canal. And this is the 7 years control on this case. So it's long time that we are doing this as soon as the reciproc and wire file has been introduced on the market. And I have called this technique sustained pressure technique. That means that we do a manual scouting, we stop in a point. The secret is that we need to fill with the manual file the possibility to penetrate in a penetrable tissue, but we are not able to do it with the manual stainless steel file because it's too soft, it's guided by hand, it's not the power to do it. So we measure this length, we put the rubber stop on the reciproc file 1 millimeter more than this length. We insert it in the root canal and we start pushing 1 or 2 seconds maximum and go away. This pushing action is just to try to put the file more in depth in the canal. So push and go away. This is also already too much time. Now we have established 1, maximum 2 seconds. Push and go away. No need to stay so long. But you can see we are penetrating 0.1, 0.2, 0.5 millimeter. Look the rubber stump, pushing and penetrating a bit. Look inside the root canal, penetrating a bit inside the root canal. We are creating our glide path in the path of least resistance. The sustained pressure, go there, activate, push 1 second and go away to obtain the patency of this root canal, then confirmed with the size 8, size 6, size 8, size 10 stainless steel file. So the sustained pressure is a technique that goes over the indication by the manufacturer, started with the reciproc 25 mm wire and can be performed also with the reciproc 25 blue, and honestly can be performed only with this file because this is the only file that has the characteristics to perform this technique to scout the unscoutable root canals in the apical third. So we can do it. I do it especially on retreatments, not in primary treatments. On retreatments, we have to open something in which we need more power. In a primary treatment, there is not a reaction of a previous treatment. So it's probably something that is given by a trajectory. So in retreatments, I use more the M-wire instrument. In primary treatments, I use more the reciproc blue instruments, or but before to use the reciproc 25 instrument for the apical scouting, I prefer to keep on my battle in a different way. So to try a different technique in primary treatments, because I prefer to use a more delicate instrument and a more delicate technique for the trying to scout the unscoutable anatomical path due to difficulties to anatomical curvature, to the presence of anatomical curvature or tight root canal, especially in the apical third. We know that when a scoutable anatomical path is not possible, if we use rotary files, our habit was to scout the root canal up to the point in which it was able to with the 10 file, then to use a mechanical file up to the point in which we reach this working length in rotation, the sequence of files, so thus performing a coronal preflaring. Then we try it again with the 10 stainless steel file to reach the working length. And we know that most of these cases with rotary files of apical unscoutable canals was given by the coronal interferences. So after the rotary preparation of the coronal and middle third, then the stainless steel file was able to follow a different trajectory and to reach the working length, and then to complete the mechanical preparation with the sequence of rotary files. This was at the time of the rotary files. The coronal preflaring was the technique how to to solve this situation. Today, obviously, we know that the coronal and middle third scouting we can perform with the reciprocating techniques that I showed you before. But if we have a manual, an apically unscoutable canals, and if you like end files, you can perform with the end files as we performed before with the rotary files. A rotary file was used up to the impediment, and then we needed to use manual files with a manual game, preventing the files 6, 8, 10 alternating small files to reach the working length with different precurvatures of this file to follow the root canal anatomy. But this was a manual game, manual preparation of the apical third, very difficult, very time consuming, very demanding, requiring a very skilled clinician. We use a precurvature, we put the rubber stop with the sign towards the precurvature, we alternate the rotation, and then we find the way of this apical third unscoutable. And then we go up and down, and if you rotate the file again, you don't find anymore the way, and you have to rotate the file with the precurvature that follows this path, and then you have to work with the number 6, then the number 8, and then the number 10 at the working length to regularize this anatomy. So you, with the stainless steel file, you are deforming the anatomy, the internal anatomy, keeping attention not to deform the apical foramen. But these rigid files used with this technique aims to reduce and to make a deformation, an intentional deformation on the anatomy of the root canals. Because we need to regularize the curvature and to make this trajectory less difficulty and more easy to be followed by the stainless steel file. And we can do only deforming this trajectory, regularizing the trajectory, reducing the abruptness of the curvature. Sometimes we need also bigger stainless steel files. The 15 is very rigid. It's very rigid and it creates transportation very easily. So it's an instrument that I don't like to use so much for doing this. I really don't like to use instruments in stainless steel more than 10 because they are very rigid. They can make deformation and transformation of the apex. But in this case, it has been used for purpose to make a deformation and a transformation on this apical curvature, not the foramen, but this stainless steel file with the apical precurvature going over this apical difficulty are used with the intention to regularize this abrupt curvature, to regularize the abruptness of this curvature, to penetrate this curvature in a much easier way. This is made for purpose, a deformation of the internal anatomy to regularize the trajectory to permit our files to reach the apex. It was done because of the limitation of the files, the rigid stainless steel files that we have to use to perform this. So if we like manual preparation, if we like the manual game, we have to perform all these steps to form the apical glide path. We have to use precurved stainless steel, small stainless steel end files, size 6, 10, 8, 12.5 to scout the apex as we have seen in the videos before. Then I like to use precurved nickel titanium and O2 taper files like the 90flex 15 and 20 to enlarge the apex once we have scouted the apex and we have pre-enlarged them at 12.5. I like to use nickel titanium in these bigger sizes because they are much more flexible rather than stainless steel. So they can be precurved with an exaggerated precurvature, and they can be used in this situation to reduce the possibility, the risk for transportation of the apex with bigger stainless steel file. But sometimes they are not enough. Sometimes to regularize this anatomy, we have to even use bigger precurved stainless steel files. And in this case, size 15, and I like to use, for example, size 17, because it's less rigid than 20, to regularize the internal curvature if necessary, if we are not able to reach the working length with the nickel titanium file. So in this case, we have to use more rigid files, cutting files to regularize this internal anatomy. And then I like to use precurved bigger nickel titanium hand file, O2 taper, and tapered 20, 25, and 30 to complete the root canal preparation apically to the impediment, to shape the apical turd to dimensions that are more anatomically guided to sizes of the apical foramen, and with a taper that permits us a three-dimensional filling. This is the technique that we normally have always used for the ledges, to go over the ledges, but that can be used the same to scout the apical turds. This is a case of ledge in a retreatment. It cannot be scouted by hand file over this point, just precurving the small stainless steel file, we go over the ledge, we overcome the ledge. We can precurve the night eye instruments with specific instruments, with specific pliers or orthodontic pliers or anything you have in your armamentarium. So I like to precurve the nickel titanium O2 Nightiflex and the nickel titanium tapered files. Those are size verifiers by Thermafil or Gutta-Fusion or Gutta-Core that can be precurved. They are in nickel titanium, taper 04, between 04 and 05. So I alternate the tapered, the O2 tapered, O2 taper, higher taper, to make the preparation of the apical third of the root canal to sizes compatible with the anatomy to promote the healing. So I need to go more than 25, even 30, and I need this nickel titanium with these sizes to avoid transportation of the foramen. And after the root canal filling, we can see the ledge and how we overcame the ledge and how we create a deep shape preparation, tapered preparation to perform then a three-dimensional filling to promote the healing together with the mechanical preparation and irrigation. And this is the 1 year control and the 10 years control of this case with the complete healing of the periapical lesion. But we have a lot of disadvantages of preparing the glide path like this with end files. The same disadvantage that we have seen before for the preparation of the preflaring with hand files. We increase the preparation time. We have the most important disadvantage is that we increase the risk for introduction of canal aberrations like ledges, zips, and apical transportation. Then this is a very difficult procedure by doing by hands. So we need a skilled operator, very long learning curve, and so the operator fatigue is very high. And then we increase the apical extrusion of debris and the possibility having a post-operative pain with hand stainless steel file and this movement to transport the debris outside. So what do we really need in this case and in these canals? Because I don't want to perform this part of the treatment with this manual technique. I don't like very much because it's very difficult and then can create iatrogenic problems. So we need in this moment a scouting file. So in the previous examples that I gave at the beginning of these lessons, we needed a real glide path file. Today we need a real scouting file, a mechanical file that permits to negotiate difficult root canals and simultaneously form the glide path and the preflaring in a safe, effective, and predictable way. So this is a different procedure rather than what we have seen before. The indications for these procedures are clear in my mind. When the use of standard manual glide path can create risks in such kind of abrupt apical curvatures, double curvature, calcified canals, with stainless steel, we can create iatrogenic errors. So these are the cases in which I want to go there with the mechanical scouting, glide path, preflaring file to scout safely, effectively, and predictably this apical third, taking the advantages of a mechanical nickel titanium files rather than a stainless steel hand file. And also, the other indication, obviously, is when stainless steel scouting is impossible in some cases and we stop, never push on them because of they are rigid and you can create ledges, zips, you can create you can move dentin debris apically and block the canal, so dentin blockages. So in this case, the mechanical action of a mechanical file, nickel titanium file, may give us another possibility to go over this impediment without using stainless steel file, so reducing the risk connected to the use of the stainless steel file, to perform what is the biggest challenge for me in this part of the treatment, to find a way of the apex, to find a way for the apex in a safe, predictable, and effective way, while reducing the risk as much as possible. So my first experience for doing this strategy and this technique was to adapt a rotary files for the mechanical scouting. It was the early 2000s. As soon as the M2 files came on the market, there was for the first time ever a small file, tip size 10 taper 4, that was the first file of the sequence, but that can be really classified as a glide path scouting file because of its characteristic. It was not a file marketed for this or with the name glide path file, but it was the first file, the initial file of a sequence. And with this file, I was able to scout the apical third of unscoutable root canals because of its flexibility, because of its cutting efficiency, but it was a file used in rotation. So giving us all the difficulties, all the risk that can be attributed to the use of a rotary file in a root canal without any prior glide path or any prior hand scouting. But the effectiveness of this file, the flexibility of this file, the safety of this file permitted me also in rotation to reach the working length in such kind of difficulty scouting in root canals, because we had not alternatives at that time. So we started to adapt the original techniques to our needs. The original techniques was that we needed a scouting with at least a 10 stainless steel file. In this case, it was not possible, but the instrument was able to perform this apical scouting, and this was the final radiograph. This was the side stand taper 4 M2 file, the first file that have changed the endodontic preparation thanks to its properties: a lower metal mass, higher cutting ability, higher tendency to advance and to penetrate the root canal, so to self-penetrating the root canal given its design, because the design was made specifically for this instrument with more blades, a constant pitch to permit the function of this instrument that was to penetrate the root canal, to scout the root canals. Very different to the aim of the bigger files of the sequence that tell only to cut very well and to give its shape to the root canal. They have only to cut and not to penetrate like the instruments in the earlier phases. So when we use rotary files for doing these scoutings, we are taking a risk, because we always take a risk introducing a rotary file in a canal that was not scouted, in which we have not the glide path. So in this case, I suggest you, if you want to use a rotary file, to reduce the speed to 150 rotation per minute, to increase the feedback in your hands, and to use obviously new instruments to perform this technique in difficult cases. This technique is a pressureless technique. Rotary files are always used with a pressureless technique. You cannot push on the tip of the file because you don't feel the tip of the file in rotation. If you push on the tip of the file and there is an abrupt curvature, an abrupt trajectory, or an impediment in the root canal, you can bend, deform the tip, or you can also break the tip. So keep attention during the use of these small files without any glide path in rotation, because the tip of this file is very delicate. So today I want to give you my vision on the ideal instrument for scouting tight, curved, unscoutable root canal in the apical third, given my experience on manual scouting and mechanical scouting with rotary files, to overcome all the limitations of the previous instrument that has been used for this purpose. So for me, the ideal instrument is again a reciprocating file, given the safety of a reciprocating file that I have clearly demonstrated and clearly explained during all my project in this endo channel. I want an instrument with an S-shaped cross-section, because again, I have already clearly explained why this S-shape, two blades cross-section, increase the cutting efficiency of the file, increase the flexibility of the file, and thanks to a specific design, increase the tendency to the advancement of a file with this characteristic. That is very important if we want to scout an unscoutable root canal, especially in the apical third. The tendency for advancement of an instrument, the self-advancement, the auto-progression is a property that is mandatory to follow a natural path that is not scoutable thanks to the mechanical file and its characteristic. Then I like to have in this case an M-wire alloy or a standard nickel titanium, and I will explain very well why. And I want to have a smaller resistant tip, so a different technique in this case. I want a small and resistant tip. I have already very clearly explained the reciprocating movement and its advantages, and the cross-section with an S-shape and its advantages. So I want to dedicate this part to explain why I want an instrument made of an M-wire alloy or standard nickel titanium, and how I want to obtain a small and resistant tip for performing this apical scouting. Mechanical glide path instruments, or in general mechanical file with small dimension, tip size and taper, they are small night-eye files, and they have a high flexibility and fatigue resistance, because all these small files for the glide path, or small files tip size 10 to 15, and low taper, they are very flexible and resist very much inside curvature. So these files, even in traditional nickel titanium, they are already very flexible. Why we have introduced metal treatments of the nickel titanium files? I have explained it in the lesson on the ideal instrument. Because we need to increase the mechanical properties of the nickel titanium mechanical files. We need to increase their properties and their resistance, and their flexibility. But in this case, in the case of a small file used for the scouting and glide path, we have demonstrated that we already have high flexibility and fatigue resistance. We already have enough flexibility and fatigue resistance with the standard nickel titanium, or M-wire nickel titanium that is a thermally treated nickel titanium with properties of an austenitic file. So this is not a limit for this file. This is a good point for these files, even in standard nickel titanium. So we don't need a very strong heat treatment, advanced heat treatment, to increase the flexibility of these files, because they are already flexible enough to penetrate any kind of curvature. So which is the limit of a small instrument for the scouting and the glide path? The limit is obviously the small tip, the small delicate tip. And in fact, for example, in this study, 88% of the torsional fracture detected in all the study were detected in small files, in small tip size files, 1004 and 1505. Higher rate of deformation, and the most frequently fractured and deformed was the 1004 and the 1505. What does it mean? This means that smaller files are more delicate and tends more easily to deform and to fracture. So we need to increase this limit and to improve this limit of these files to have the ideal file for the scouting of the apical third. So why M-wire? Even more than the standard nickel titanium. This is because of the metal properties of these files. We know that martensitic files, heat-treated files like blue file, gold file, EDM, TF, martensitic or air phase file with these advanced treatments, they have improved the fatigue resistance and improved the flexibility of these files, much more than an austenitic file like standard nickel titanium or M-wire nickel titanium heat treatment. But in this case, we need resistance to the axial torsion, not flexibility. So martensitic or air phase file has a lower force needed for deformation. Because they are more flexible, the metal is more ductile, as I have already described in other parts of this endochannel. So they are more prone to plastic deformation. Martensitic files, air phase files, they are more prone to fracture or to deform more than fracture, because The angle at deformation, the angle needed to deform is longer, is higher, so they fracture less, but they deform more easily because the metal is more soft. So I want to take advantage of the characteristic of an austenitic file like the M-wire heat treatment to increase the torsional resistance of a file with this characteristic, to increase the resistance to deformation to the axial torsion. That is what we need on a file with this characteristic. We need the, I call it gray power on an M-wire and an austenitic file that has less tendency to the unwinding in these cases, because these cases, the more delicate part is the tip that should resist the torsional stresses while scouting a very difficult and complex root canal. And the M-wire has the material properties, the matching geometry, and the intended use for this feature, with the flexibility and rigidity in the middle between standard nickel titanium and blue or heat-treated files with more martensitic behaviors. So the air pilot file, the first reciprocating glide path file that I have already showed you as a universal glide path file, is also the instrument of choice for me to scout these very difficult root canals. We can say that this is the son of the M2 10 taper 4 file, and it comes from our experience while using this file invented by one of my mentors and one of my best friends, Professor Vigno Malagnino, that I would like to thank for this invention and for his ideas and his revolutionary mind, because this instrument have changed my life and the life of most endodontists in the world. This instrument has introduced a lot of very important features, and the air pilot files, I can say, can be the son of these instruments, in which me and Nick Grande, with other endodontists in the world, we have cooperated with the creation of this air pilot file by asking for specific features to overcome the limit of the M21004 file and the fact that the tip was very tiny and delicate. So the first features that we asked for the production of this file, starting from the initial prototypes, was to have a fat S-shaped cross-section, a little bit fatter rather than the normal cross-section that we had for M2 and also for reciprocal files. So the M21004 has a different, slimmer cross-section rather than the air pilot. And furthermore, the air pilot has a 12.5 tip. So the tip was increased a bit in size, more than 10, to have a little bit bigger tip to withstand the torsional stresses. The taper is the same, but the cross-section is a little bit different. This S shape is a little bit fatter. Why fatter? To include a little bit more of metal mass, maintaining the two blades S-shaped cross-section, that is very important for the cutting ability, but increasing the resistance to torsion by increasing the metal mass inside the cross-section. This will not reduce the flexibility of a file like this, so small like this, but this will increase the resistance to torsion, to withstand the torsional stresses. Another feature that we asked was for a variable pitch length with blades that are nearer at the tip respect to the M21004, for example. Again, this pitch length, shorter pitch length at the tip, aim to create more blades at the tip that increase the tendency to advance to autoprogression of the instrument inside the root canal. And more blades, nearer blades gives again more metal mass at the tip. So we have more resistance at the tip because more metal is present at the tip. Then in the coronal portion, this instrument, the pitch length is similar to the M21004, so it's a longer pitch length, because in the coronal portion we don't need these features. In the coronal portion we need only a feature to cut in brushing, to cut in lateral action, to cut and to advance. So in this part we don't need to increase the torsional resistance, we need to increase the cutting efficiency of the file. So we need more vertical blades to increase cutting. Then this is made by an M-wire alloy. M-wire is a heat treatment made on the raw wire, so it is not made on the already milled material, milled file. It has been demonstrated to increase the mechanical properties of respect to the standard nickel titanium alloy, but we call it like a mild heat treatment because it does not change so much the properties of the file, the macroscopic properties of the file. If you have in your hands, this is just similar to a standard nickel titanium, just with a little bit enhanced mechanical properties, but in austenitic phase at room temperature. And with this technical feature, we aimed to overcome some limits of the rotary files and that we had in the past to perform the mechanical scouting. And for example, in this case, as I usually do, to compare two files, I use before a file and then the file that I think it may be an evolution of the file that I was trying. So in this case, I tried to scout these MB1, MB2 root canals directly with the mechanical files with the M2 in rotation, and then with the air pilot, because with the M2 in rotation, I had a small deformation at the tip, a small deformation given by the difficulties in scouting, mainly due to the rotation, of course, but also due to the design of this file. The air pilot file, this one on the right, you can see it's very difficult. It's very different in the design at the tip, much shorter pitch length, much shorter pitch, a little bit more metal mass with the blades that have less space in between the blades and less deep constructed blades. So this file in this case helped me to reach the working length where a rotary mechanical file was not able to reach. And the first articles published on the literature are demonstrating that the cyclic fatigue resistance of this air pilot file is significantly greater than other rotary glide path files present on the market, both in single curvature or in double S-shaped curvature. So even tested against mechanical files for the glide path that have been thermally treated, like the HiFlex or the other glide path files like the Gold Glider. So in this case, even if we have a less strong thermal treatment like the M-wire, the cyclic fatigue resistance was greater. That means that the design plays a role and increase the fatigue resistance of this file, despite the metal treatment is less prone to create a flexible file. So this design is, for me, the best design for a file for doing this. And other than being a universal glide path file, as we have described at the beginning of this lesson, if we want to think outside the box, this will become also a file for a mechanical scouting directly inside the root canal without any hand file before, up to the apical third. Because I try to explain why a night-eye small reciprocating file is better than an hand stainless steel file of small dimension to scout difficult apical anatomy. The reason are that they have similar dimensions. Small night-eye mechanical file like Air Pilot or small stainless steel manual file like a size 10K file. But nickel titanium is more flexible, so we take the advantage of the flexibility of nickel titanium, and moreover, the mechanical movement through which it is used is more efficient than the manual use. This is very important because mechanically the mechanical movement increase the properties of the file, the flexibility of the file, the efficiency of the file, and the reciprocation increase the safety of the file. So in this case, we have a file that is very nicely designed for the scouting and has a lot of advantage in respect of a manual scouting. It takes the advantages of small files and the safety of the reciprocation, as already cited by Ghassan Yared in this article, in which he has used a small stainless steel size 10 or a small rotary file like the M2 used with a particular reciprocation to reduce the risk for fracture in scouting this root canal, to perform this big challenge at our best to find the way of the root canals. Let's have a look on the different clinical cases in which you can apply these properties for a mechanical scouting direct with a mechanical reciprocating file. This is a retreatment of a first upper molar in which obviously we have a lesion of the mesial root, and we obviously will find a missed MB2 root canal. We know it even without a CBCT. So as soon as we accessed the root canal, I started using a glide path file in rotation here, designed for doing the preparation in rotation, that was deformed inside the root canal at the end of the preparation. Why? Because of the rotation, because of the design of this file. It was not able to penetrate, and at one point it starts deformation because of the rotation and because of the design of this file. This is the air pilot file used with this packing up and down movement that we will describe it better later, and this arrived to the working length in this particularly difficult MB2 root canal without deformation, thanks to the reciprocation and to the design of the file. This is the difference macroscopically, the air pilot here, and here there is the other file used in rotation, the deformation, and the air pilot not deformed that scouted this apical third thanks to its properties. So if we compare this file with other file, honestly, all the tests that I did, the air pilot file win against all the other scouting glide path files, and this is the final radiograph of these root canals in this curved mesial root. This is another case in which, in this lower molar, we tried to scout the apical third manually, but I was not able to reach the final working length under the control of the apex locator. I still missed 1 or 2 millimeters. Again, I used another file in rotation, trying to scout this root canal mechanically, and again I had a deformation, and I was lucky that in rotation I had not a fracture. But I had a deformation because of the risk given by the rotation in these cases, and probably also the design of the file not made specifically for this purpose. The air pilot file, again in the same canal in which another instrument failed, reached the working length effectively and without risk for deformation or fracture. Which is the clinical use of this file in this situation? This is a micro packing action, faster, shorter, and delicate packing movement like the Woodyfoot packer action. That means that in this case that we have not scouting of the root canal with hand files before, we need to adapt a little bit our movement with our hand. And this is the movement that we like to perform in this case. We insert the file inside the root canal, not in reciprocation, and then we reach the point in which it may bind, and we start the movement. We start the motor movement. As soon as we start the motor movement, we perform this up and down, short and fast movement, just pushing a bit on the tip of the file. And look, it's proceeding very slowly towards the working length, gaining that 2 millimeters that I was missing on the clinical case. And look at the shape of the tip. It was having the shape of this particularly difficult apical root canal. And this is the technique, up and down, short, fast movement in a delicate way, just pushing a bit on the tip and go away for 4 or 5 times. This is done for a reason, because even if the reciprocation is virtually safe for torsional fracture, if we block the tips of the file for an increased number of cycles or a certain time, it may also break. It may break also if we use it in reciprocation because of the rotary effect of this reciprocating movement. What does it mean? It means that if we do this packing movement, pushing like the sustained pressure technique too long, and we engage the tip may break because it has this rotary effect. So we have in this technique to reduce the cutting time for the air pilot file. So the time before fracture or deformation will depend on the feature of the files, dimension, cross-texture, and metal used. So in this case, we need to reduce the cutting time of the tip of this file. So we do faster packing action. just to reduce the amount of dentin to be cut and the time in which the instrument is cutting and in which the instrument is rotating in reciprocation, cutting the dentin. So reducing the risk for fracture of this tip. This is very important with this technique, and this is the clinical case that we were showing before, with the tip of the file reaching the final working length after this technique. And this is then after root canal preparation and final filling of these root canals with this particularly difficult anatomy. Again, other similar example, small root canals, very strict, in which it was not possible to perform the apical scouting manually. Again, I used two different files to try and compare them. I used the Wave 1 Gold Glider file and the Air Pilot file. And as you can see, the gold material is softer. It's softer, it's not made for this purpose. In fact, the direction for use for these files is that you have to use after scouting with the 10. You cannot scout a root canal that is unscoutable because the gold treatment increased so much the flexibility of the file, but reduce its torsional resistance. So in this case, we need more torsional resistance to withstand the torsional stresses in these procedures. And in fact, in this procedure, the gold glider distorted, while the Air Pilot reached the working length without any difficulties or any effort. Then you see the final radiograph, it seems, yes, it's a curved canal, but you don't appreciate the difficulty that we had in the scouting because of some problems in the apical third that is not depicted by this radiograph. And then this is also the other the second lower molar treated. So differently from the hammer that we have used for the coronal scouting, here we need a Ferrari for a fast and furious scouting of the most difficult apical complications, curvatures and difficulties due to trajectory apically. We need to maintain our instrument inside the curvatures, inside the curves, without going off-road. So to scout the unscoutable root canals, this is the aim of this lesson. And scouting the unscoutable root canals, in some cases, we need to use all the weapons that we have in our hands. Those are some really particular, very difficult cases in which we can join the different weapons that we have, the different instruments that we have. And this is the classic case, example case that I do. A retreatment of this first upper molar, lesion on the mesiobuccal root, obviously an MB2, a missed MB2 root canal. Here we summarize all the techniques that we have seen up to now in orifice location, glide path preparation, scouting, and instrumentation. Look, I have found the orifice. I found an invitation. I tried with a small glide path file in reciprocation, but this small file does not have the power to penetrate this dentin. There is an invitation, but this invitation is closed. This orifice is closed. There is not space for this file to penetrate this orifice and this trajectory. So the small file has not the power in its tip to perform it. First choice is to use again a little bit of ultrasonics to go a little bit deeper, to remove a little bit more discalcification, discalcified tissue. In these cases, nothing works, so we have to remove more tissue deeper in the root. And I use the ultrasonics to perform this. You can activate water if in the moment you don't need to see perfectly what you are doing, so you remove the dentin powder and the dentin dust, and going troughing through the isthmus, looking for that black spot at the end of the isthmus that is the orifice of the root canal. Hand files doesn't work at all in these cases. It doesn't penetrate even 1 millimeter. So again, the orifice is there. I have identified. Again, I tried with the small reciprocating glide path file, but again, this tip is too small. It does not withstand my axial pressure to try to penetrate this anatomy. So I'm pushing a bit on the instrument, performing an axial pressure, trying to penetrate this orifice, to engage the first blade of the instrument to cut and to remove this dentin that would permit the instrument to advance even more. So I took a different file. This is the reciprocal wire file, single file with a bigger tip size, more rigid, in which that can withstand my axial pressure. Withstanding my axial pressure, it can start to cut, as you can see, the dentin debris created. It starts to cut at the orifice, engaging the tip and engaging the blades, but it's still not proceeding so much deep. But we create again a bigger invitation, but was not starting to cut, but was not able to continue to penetrate. So again, in this case, the manual file is not able to penetrate anything. Again, in this case, we have to use a more aggressive technique. So in a dynamic way, as I have insisted very much in my lessons on this endo channel, a dynamic way, we go further and then we go step back if it's needed to improve the treatment, if it's needed because the further step was not able to proceed to the next one. So again, we tried mechanically to be more conservative, it was not able. Then we took our ultrasonic tips to go deeper inside the root. So going deeper inside the root, we remove more calcification, we make the trajectory easier for the file, we create more space, and then finally we can try with the mechanical files, because again, end files here, like you see here, doesn't penetrate anything in this orifice. But as soon as we use the correct file, as soon as we have tried different strategies, in this case the reciproc R25M wire has the power in its tip to penetrate these 2, 3, 4 millimeter of coronal dentin that represented the coronal impediment. Look, this is penetrating with the tip, cutting, following the path of least resistance given by the root canal, removing the coronal interference, enlarging the coronal interference up to the point in which we had the difficulties. Then I, in this case, used again the AirPilot file, in small reciprocating file, because I felt in the reciproc very difficulty to advance more apically. So we solved the coronal problem with the reciproc file, and then we approached the more apical problem with the smaller AirPilot file. And this is what was successful in this case. As soon as we have opened the coronal portion with a bigger file where this smaller file couldn't penetrate, then the smaller file could advance more apically, more easier than a bigger file that couldn't penetrate so well more apically to that impediment because of the tip dimensions and taper. And so slowly and very delicately, we advanced with a packing up and down movement and brushing lateral movement to remove the coronal interferences, to relocate the orifice, to make the trajectory in the coronal portion easier for the instrument to reach the apical third because of the difficulties of this root canal. Look, we took the time needed for the instrument to reach the working length. As soon as we arrived to the apical third, we tried to confirm the apical patency with a stainless steel file, and we, as soon as we have removed the coronal problem with the reciproc and the apical problem with the AirPilot, I was able to reach the working length with the stainless steel 10 file, and then to complete the scouting, the glide path preparation, and the pre-flaring preparation in this very difficult case with the AirPilot file up to the working length established with the hand file. So in this case, very difficult. Even if I have scouted the canal with the 10, I like to insert another file before the single file to pre-enlarge the root canal, for a pre-flaring of the root canal, to make the life easier for the single file that has to reach the working length. In this case, we create a pre-flaring, coronal, middle, and third pre-flared and pre-enlarged for the following instrumentation with the real file for the instrumentation of this root canal, that in this case was the reciproc and white. This is an old case. Today I would like to use in this case the reciproc blue because it's more flexible, and I have seen how much difficulties I had with even the small files in this case, but the reciproc was even effective in this case to reach the working length. So reciproc blue should be now my choice, or in these cases, a file that can reduce the taper of the coronal preparation to reduce the amount of dentin removal in the coronal third, and we will see this in the last part of this lesson. So here we are reached the working length after this very hard work on this root that is not explained by this radiograph. It seems a very simple mesiobuccal root with 2 root canals, but it's quite straight. So we cannot appreciate how much difficult it was this case, with probably curvature on other planes rather than what we see on the radiograph. And those are the controls after then the restorations and after 1 year. So this is the case solved with this approach. Let's go to have a look to another case solved with an approach again using multiple files to solve this situation. MB1 root canal was scouted while the MB2 root canal was impossible to be scouted. I started in this case, as I always do, with the file that I consider less effective, the Way1 Gold Glider, trying to scout the MB2 root canal, but looks how soft it is, how much it bends. It bends very much, and it has not the power to penetrate this impenetrable root canal. So, following my instruction, I then used a single file, a bigger single file, to overcome the coronal problem, so the Resiblock blue file. So here, I tried with the tip of the Resiblock blue file. I started to try penetrating it, but it was not so easy to penetrate it. Again, it starts to cut, you can see the dentin debris, but not penetrating the orifice. So in this case, I took the third instrument, the other solution, a small glide path file like the AirPilot file, that started to penetrate that small invitation that the Resiblock blue created in this very calcified but penetrable orifice, and look, pushing a little bit on the tip, up and down movement in a pecking action, cutting the dentin. The sides of these files were compatible to penetrate these dimensions of the root canal. The cutting efficiency was good enough to cut this dentin and to penetrate and to advance, and the flexibility was so high that it can follow the trajectory. So I started scouting with the AirPilot, then I took back again. I felt this curvature very strong. So I took back again the Way1 Gold Glider because this gold treatment enhanced the flexibility of the file. And so I tried again with the Gold Glider to penetrate more apically this root canal, but again, this is a softer metal and it was not possible. Look how much it bends more rather than the AirPilot in M-Wire. I tried to do brushing, I tried to push a little bit, but it was not possible to advance because this file has less cutting efficiency given by the metal treatment and the design of the file. So as soon as I feel that I need to push on these less effective files, I stop and I go back again with my file of choice, the Resiblock, the AirPilot file in this case, and I still pushing a little bit on the tip, doing this packing motion up and down with brushing lateral movements to remove and relocate the interference and relocate the orifice. And look, after removing all the calcification, we reached the apical third where bleeding pulp was removed after the calcification. And this is the work that the AirPilot does and the other instruments are not able to do. And this is the picture of the instrument that I used after this. The Gold Glider again deformed because of its lower resistance to torsion given by the metal treatment, the martensitic file, and the less cutting ability. While in the same canal, the AirPilot was going towards the apical third like this in this double curvature. And those are the MB1 and MB2 after the preparation and after the filling. So this is my instrument of choice, and I am demonstrating you why it works better than others. But there are some situations in which we may need a martensitic glide path file, like the Way1 Gold Glider file, for example. They are, for example, standard root canals. These instruments, they are standard root canals, but very curved root canals. These instruments are indicated after the use of the size 10 stainless steel file to scout the root canal and to establish a glide path for this Way1 Gold Glider. So this is a play-flare file that can be used in very curved root canal with coronal curvature because of its flexibility, standard root canals. So that does not need very much properties for scouting these root canals, but can be scouted with a very flexible, effective, and efficient instrument like this one, or in patented but very difficult root canals. Difficult root canals, but that must be patent. That means, for example, an MB2 root canal. Those are the MB1 root canal treated with this with the Way1 Gold Glider. Look, without any scouting, even in this case, but it was a patent root canal, even if difficult because of the curvature. But we could treat this patent root canal thanks to the properties of these files. So normal standard cases can be also treated with these with the files with other properties. But the most difficult root canals, they were really difficult to be treated by other files other than the one that I suggested. This is another case. Another case, this upper molar retreatment, 1, 2, 3, 4, 5, seems they're strange anatomy. Let's have a look of the internal anatomy of this tooth after we reopened the access cavity. We went to the ultrasonic troughing through the isthmus. As soon as we find an orifice, this was a non-treated MB2 root canal in a retreatment. That means that probably for me it's the easier root canal because the other colleagues has not touched this root canal. So it's a primary treatment for this root canal. And again, the small air pilot file used with 3 up and down pecking motion, 3 to 5 up and down pecking motion, irrigation, and again 3 up and down pecking motion. This is the clinical technique how to use it to penetrate this root canal very, very slowly. But you can see that advancing very slowly, 1 millimeter or less each time, each PEX, we are able to deliver the instruments to proceed safely because it is in reciprocation, so it never binds past its fracture resistance or deformation resistance, but it's also effective in cutting dentin even if it's small and flexible enough to follow any curvature possible in this case. So technique how to scout these very impossible, difficult root canals. And then after opening this orifice and this root canal up to the apical third, we can proceed with our standard procedures, with our standard file for the root canal preparation. In this tooth that was quite particular and quite difficult, in this case, we completed the MB2 preparation, and then we understood we finished the MB1, understood the different anatomies that we can appreciate here. 2 distobuccal canals, distobuccal 1, distobuccal 2, 2 mesiobuccal canal, mesiobuccal 1 and mesiobuccal 2, and 2 palatal canals, palatal 1 and palatal 2. So there were 6 root canals in this particular root canal anatomy, filled again with the filling techniques. Those are the images after filling and the radiographs after filling these 6 different root canals of this upper molar. Those are the 2 distobuccal and the 2 palatal canal. Here there are the 2 mesiobuccal root canal. This is after the reconstruction and after 2 years which we are going to perform a prosthetic treatment. So I like to define me like a Robin Hood endodontist because I like to use all the arrows that I have in my bag to solve the most difficult cases. And there is a last classification, last type of cases in which I need to access to different arrows to finish my treatments. We started from standard case that can be completed with just 1 file to more complex case in which we need probably 2 different files, to other cases with tight root canals, very tight canals, extreme double curvature, in which the tough decision ahead is that probably we need, after a reciprocating scouting glide path file, we need to insert in the middle another file before single file use to go back to a reciprocating sequence in this very few amount of cases, very few number of cases, in which the root canals, they are so strict, so constricted, or they are so difficult double curvatures that after the glide path file, the air pilot file that create the glide path and the preflaring, and before the use of the reciproc blue file, we should use another file to create a smoother preparation for our legal file for preparation. So in this case, I like to use the VDW rotate file, especially the 20 taper 5, because it's the very good size in the middle between the air pilot and the air 25. In this case, this is a rotary file, but as I usually do, I use this file in reciprocation with the specific reciprocating motors, because the motor in which this instrument should be used have a reciprocating movement for the reciproc that cannot be used for the rotary file. So we need a motor for applying reciprocation in the clockwise direction. So clockwise reciprocation rather than the counterclockwise reciprocation that we have for the reciproc files. So in this case, very tight canals, double curvature, scoutable, small glide path file in the middle, and final reciprocating file to scout these double curved root canals and to have a smoother advancement towards the apex, a smoother enlargement of these root canals that helps us to maintain a better anatomy of these root canals. Another similar case, first file in the middle, file for the preparation, and final obturation of this double curved root canal, very difficult to be treated. So in this case, I use this sequence of the files. Again, another double curved root canal, different files used, the scouting glide path file in the middle, and the final file for the preparation, and this is the final three-dimensional obturation of this case. So the take-home message from this scouting lesson is that when we have scoutable root canals, we can scouting, if you like, and files, we can scout with stainless steel files, then glide path with a stainless steel file, and then shaping with our instrument of choice. If you like mechanical glide path, after the stainless steel scouting, we can perform a mechanical glide path with a reciprocating glide path file, and then the shaping with our instrument of choice. If you like mechanical instrumentation in general, we can perform scouting, glide path, and shaping with our instrument of choice, just limiting the apical scouting to a manual stainless steel file. And if we have a scoutable canal, we have to choose different files. For the coronal scouting, we can have a single file used in reciprocation, ideal for the removal of the coronal impediments. For the apical scouting, we can use a small glide path file for the scouting of apical impediments, and we have seen we can use all these files alternated to solve the most difficult situation, in which probably we need to adapt all the technique before to finish our shaping procedures. Obviously, if mechanically everything fails and we are not able to penetrate this apical third, this is a manual game. In some cases, probably we need to perform everything manually, or in some cases, we may have some difficulties to perform the scouting, and we need a shapeless preparation in the apical third, and we need to stop there to increase the irrigating procedure, as we will see in a further lesson on the endo channel, and adapt our techniques for this. So, opening my door on this topic and on other topics, I would like to give you appointment to the next step of this endo channel, speaking about apical preparation and its importance on the success on the endo channel by Gianluca Plotino.